Hi, I'm Heather Berwager, and I'm joined by Justin Fugazy, the head of client engagement at Revecore. Justin, thanks for being here. I'm excited for our discussion.
Yes, I'm excited as well. Thank you.
So, for a long time, we know that revenue cycle performance was measured in a relatively stable financial environment. The industry optimized mostly around efficiency, so cost to collect, staffing ratios, turnaround times. But that environment has changed. So, we know that margins are thinner. We know that denials are harder, are rising, and underpayments are hard to detect. And more revenue cycle leaders are starting to ask a different question entirely, not just how efficiently can revenue be collected, but how much revenue are we actually failing to protect? And so that's our conversation today. Why more organizations are shifting from a cost to collect mindset to a ROI mindset when they think about revenue cycle investment. So, Justin, before we get into the numbers, can you give a little bit of context on the perspective that you bring to this discussion?
Certainly. Thank you. I lead the client engagement team here at Revecore, and I spent the last 20 years on the vendor side helping our hospital partners recover every dollar that they have. We're doing so by not focusing on renegotiating contracts or changing reimbursement rates for the facilities with the payers, but instead ensuring each dollar that has been earned is getting captured and recovered for them. It's about closing the gap between what should be paid versus what is being paid today. So many organizations are still relying on metrics that were designed for a simpler reimbursement environment where there was lower denial rates, more predictable payer behaviors, and wider margins to absorb some inefficiencies or absorb some difficulties that may arise with the reimbursement process. The cost to collect is still a valuable metric, but it's no longer sufficient by itself. Success for a revenue cycle needs to be measured through that return on investment, revenue protection, and the completeness of that collection.
And you mentioned margins. On paper, operating margins improved somewhat in 2024 and 2025. But at the same time, we're seeing that a lot of health systems still feel financially fragile. So, can you kind of walk us through that contradiction?
Yeah, certainly. In 2024 and 2025, the recoveries were real, but they were shallow and they were inconsistent with where they were coming from. They weren't durable and sustainable over time. So positive margin, um, it does not necessarily mean that it's durable and sustainable as we're seeing today. And low single digit margins leave very little room for any disruption, whether that disruption is coming from payer uh, payment cycles, whether it's coming from labor pressure or investment in additional technology, or if there's volume shifts within utilization centers within. So expense control and volume recovery has helped in 2024 and 2025, but the reimbursement pressures remain today. So days cash on hand, the liquidity remain pressured today, and the financial shock absorber, as I referenced, it's not there when we're operating on that 1 to 5% margin that most hospitals are operating at within the country. So while the headline margins are improving and have improved, it's not flowing through to the margin line. And so what I mean by that is the denials, underpayments, and payer audits that are taking place today have erased all those gains or a lot of those gains that we are seeing through 24 and 25. So the bottom line is the industry saw some recovery, but not enough resilience. And so now we need to look at revenue cycle as a form of risk and financial risk control.
And let's talk about what that leakage looks like operationally. Where is the revenue disappearing?
Yeah, so the leakage is happening throughout the continuum of uh, revenue cycle. So there's no single report, so there's no single location to look and identify exactly where that leakage is coming from. So let's take a look at a couple different areas. So we have denial rates; they're continuing to rise. The average value of each of those denials is also rising. That means each individual denial that's coming back to a healthcare organization has a greater financial impact to that healthcare organization. Another problem is a lot of these claims, a lot of these denied claims are not being resubmitted. That ends up becoming a permanent revenue loss versus delayed cash. The commercial underpayments as well, which we briefly mentioned previously, they're oftentimes going undetected because the claim appears to have been paid. Perhaps it wasn't paid at the full rate, the contracted rate, or the full reimbursement that was eligible to the healthcare organization based on some coding or based on severity of the location of treatment. So because that cash is coming in, oftentimes these underpayments are being overlooked. It's being seen as cash in the door, we're good, we're going to move on. So we need to identify where those underpayment opportunities happen as well. On top of that, we have payer audits. Those are increasing with frequency and they're increasing with value. So now healthcare organizations are not only spending time and money to submit the claim, they're then spending time and money to resubmit the claim if it's denied. And then they're spending time and money to defend the payment in which they've received. Now exacerbating the problem, more revenue leakage. So across those three areas, again, not a singular report that's going to capture everything for us, but if we're looking throughout the continuum of the revenue cycle, we can start to piece that together and identify the full leakage.
It's a tough environment to be in, but cost to collect has been sort of the industry's default for decades, but you've argued that it misses something important. So what's the flaw?
Yeah, certainly. The cost to collect is a valuable metric. It's just not a complete metric. Uh, it measures the operational efficiency of collecting each dollar in the door. But what it's not capturing is the completeness of that collection. What is still out there? What could I be collecting? What should I be collecting? The fundamental question that cost to collect is missing is how many earned dollars does our system have that were never collected? Measures efficiency, not completeness. An organization can show a low cost to collect while still losing millions in untouched denials, missed underpayments, and premature write-offs. I like to highlight the incompleteness of the cost to collect metric by taking the metric to its logical extreme. I can bring cost to collect to near zero. I can do that by never billing a claim, having no processes internally, having no staff to bill those claims. If I were to remove all of those functions, my cost to collect would reach near zero. My revenue would also reach near zero. And my point in this is cost to collect, valuable metric, not a standalone metric. We need to couple it with the return on the investment to increase and maximize what reimbursement is available.
And that's the perfect lead in because my next question is if cost to collect is the wrong framing, then what's the better question?
Yeah. So the better question, we need to shift from how cheaply can I collect to how much earned revenue are we failing to capture and what would it take to capture it and then prevent it. That shift will move revenue cycle from a cost center to a revenue protection function. Example, if I invest $1 million and I recover $15 million, that's not merely a $1 million expense. It's a margin generating business case. Preventable leakage may exceed the savings available from trimming another fraction of a point from a collection expense. So protecting the revenue does not require significant shift in patient volume. It doesn't require significant investment in renegotiating contracts with payers. It doesn't have to do with payer rate increases. It's identifying where the leakage is occurring and making subtle shifts along the way to ensure that it's being prevented.
And then when organizations start measuring through more of an ROI lens instead, How does that change the conversations that revenue cycle leaders are having with CFOs or with their boards?
Again, we're moving away from what does this cost? And so we're going to shift to what revenue is this protecting? What cash is this going to accelerate? What margin improvements is this going to create? Boards, CFOs, financial professionals, they understand investment, return, cash, margin, risk. If I were to come with a stat of this particular process has a 2.8% cost to collect, the great benchmark to have, but it's incomplete. It needs context. It needs explanation. It needs what is good, what is better, what is best. If I come with this has a 10-to-1 return on my investment, that is immediately understandable. ROI strengthens a business case for prevention by tying software, staffing, implementation. Of, it paints the entire picture of what is this going to cost me and what am I going to receive in return. At the CFO level, almost every initiative maps back to one of three outcomes: margin, cash, capacity. By painting the picture with the ROI metric, we're able to tie to what the CFOs are currently driving.
And you were talking about what the environment has been like for hospitals lately. So, why does the ROI framing become even more important in a low margin environment?
In a low margin environment, small improvements have an outsized impact. So, increasing margin by a quarter of a percent on a 1% margin business is a 25% increase in your margin. A 0.25% increase on a 50% margin business is relatively small. So for many systems, it's going to represent millions of dollars. Those small incremental changes can represent millions of dollars that are going to flow to the bottom line for our hospital clients. Again, it does not require new service lines. It doesn't require new facilities. It doesn't require new payer contracts. It doesn't require a lot of the laborious or labor intensive processes necessary to increase the revenue for the facilities. Instead, quick shifts, quick implementation, and able to capture what that might look like. Investing earlier in the life cycle is going to have, again, an outpaced impact on the overall business. So moving from a recovery model to a prevention model is also going to generate outsized impact, financial impact for the organization. Delayed cash for organizations or lost cash from an organization has significant downstream impacts as well. So it's going to negatively impact the forecast reliability, the working capital for the organization, and sometimes financing capacity could be negatively impacted by that delayed or leak uh, revenue that was subject to.
Mm. And if a revenue cycle leader wanted to, let's say, start building the case for an ROI case, where should they begin?
So first, painting the picture of the completeness of the revenue leakage. Not coming forward with generic promises of improvement, but instead working through measurable leakage. And I would suggest starting in a few areas. So first, we need to calculate the total leakage. Unrecovered claims, unrecovered denials, missed underpayments, and other identifiable reimbursement losses. Listing out what all of those are. Then estimate a realistic recovery portion using credible assumptions and metrics that you already have internally based on your data, your workflow, and your capacity. Do not claim that every dollar of that leakage is going to be recoverable. While sure, we would love to have 100% of this recovered, it's not realistic. Calculate the annual impact of what that realistic percentage is. What is that recovered revenue? What is the avoided future leakage worth? What is the cash acceleration worth? And what is the legitimate labor efficiency gained from that change? And then step 4, compare that total impact with the required investment to show the ROI. What is the net gain after you pay fees, whether that's labor or through a vendor? And what is that payback? And you can generate and calculate your ROI from that. So a denials example. Isolate claims that were never resubmitted. Estimate a recoverable yield on that population. Compare that opportunity with what it's going to cost to pursue that. That is your ROI in the denials piece. Underpayment example. Quantify the leakage. Use a conservative recovery yield. Subtract fees, again, whether that's labor cost or vendor fees. Any operating costs that you're going to incur to track that down and get those reimbursed. Generate your net return. Speak the CFO language, margin protection, liquidity protection, revenue integrity, the cost of inaction. Those are real values that we need to put dollars to, put an estimate to. Build credibility with focused opportunities, transparent assumptions, and measurable wins. We're better off projecting a realistic recovery amount and achieving it than an aspirational or 100% recovery that we're going to fail to achieve.
And you talked about kind of the right way of going about it. From what you've seen, what's the biggest mistake that organizations make when they first attempt to calculate revenue cycle ROI?
Using an opportunity estimate that is entirely too broad or entirely too optimistic. Credibility matters, as I was just saying. Distinguish that total leakage from the realistic recoverable amount. Document your assumptions. Ask others to look at your assumptions. Challenge your assumptions. Find other ways to recover those dollars. Mistake number 2 is measuring departments independently. A change in one department will have an impact on another department. Identify what those impacts are. Is it an efficiency gain? Is it a prevented denial on the front end is going to have a reduced workload on the back end? So identifying what all of those are, don't assume that these are being worked in silos. A change here will impact there. And they all need to contribute to the same financial objective. Protecting earned revenue today is more valuable than recovering lost revenue.
And before we wrap, I want to give you kind of the last word on this. If revenue cycle leaders take one idea back to their finance teams today from this discussion, what would you want that to be?
The singular theme I would want to be captured from this discussion is revenue cycle is no longer simply an operational expense that needs to be minimized. It's a strategic revenue protection function. And the cost to collect tells us how efficiently we're collecting, but not the completeness of our collections. ROI is going to tell us how much revenue we protect and what return is expected and we have achieved from the investments that we make. When margins are only 1 to 5%, every prevented or recovered dollar has an outsized impact to the organization, the financial outcome of that organization. Connect denials prevention, underpayment detection, and recovery to margin, cash, and capacity. Speak the language of the CFO, speak the language of the board, and to measure what it costs to collect, we need to also measure what is not being collected, and then what we can realistically do to maximize the collections of currently what is going uncollected. The final line is, this is how we're going to move revenue cycle teams from being focused on operational reporting to financial strategy.
Well, Justin, I think this gives a really useful framework for not only how revenue cycle performance is measured, but also how it's evaluated and funded. So thank you for the discussion.
Thank you very much.